Hi there and welcome. My name is Dr. Marlena Jabara, and I'm the proud founder of RadPodSquad. The RadPodSquad Fellowship offers an immersive learning experience tailored specifically to podiatric imaging. We've designed our curricula to elevate your confidence in this specialized field. RadPodSquad combines comprehensive curricula, cutting-edge techniques, and on-demand access to training that will provide you with the new knowledge and skills that you need to boost your confidence in imaging and truly make a difference in treating your patients. Check us out today, radpodsquad.com. When we look at Charcot versus infected Charcot, in the setting of chronic Charcot, what we'll be seeing is a swollen neuropathic foot. We're not seeing an ulcer in that case. So in Charcot without an ulcer on x-ray, we can predict there'll be joint deformity, dislocation, that rocker bottom change we saw on the last tutorial. And in the MRI, the pattern in a chronic Charcot may be no marrow edema. Now, if we now have superimposed infection, that situation looks like we are going to have an ulcer, which is going to be an area of direct spread of infection. And we can see that sinus tract extending into, in this case, the cuboid. Predictably, the cuboid becomes weight-bearing after the first and fifth metatarsals lose their neuropathic sense. So we can predict a lot of changes in these Charcot, chronic Charcot patients. So let's take a look at a case. This was a patient who presented with Charcot versus osteomyelitis, comes with pain, a swollen foot, and we can see right away on the x-ray that the posterior subtalar joint is malaligned. We have the sclerosis, fragmentation, and debris. There are bone fragments here that are articulating with the navicula, suggestive of a talonavicular Charcot neuropathic dislocation. And of course, the AP view certainly shows that medial dislocation of the talar head, fragmenting the navicula and fragments here in a patient that is consistent with Charcot fracture arthropathy. And the MRI for that patient, we can see the tibio-talar subluxation that's occurring here in this varus angulated patient, and even more that the calcaneus is lateral to the talus. So this is a talocalcaneo complete dislocation. And what we're really trying to assess on this patient, if there's the presence of an ulcer, is where the T1 infiltration is. Luckily, in this case, there was no ulcer. What I'm pointing to here is this soft tissue rind of high signal on T1, which is consistent with fat. So there's a normal fat plane maintained. And what we can see is the extensive neuropathic subluxation, dislocation, and fragmentation that has occurred. Here's your navicula and fragments of bone, but they are not infected. Without an ulcer, it's not likely to be infected. Adding contrast enhancement to these cases can help us in the setting when there is an ulcer. So in the beginning, when there is an ulcer, we can see whether or not there'll be T1 marrow infiltration. So we're basically going to be assessing the presence of an ulcer. If there's an ulcer present, we want to be able to look at the bone directly adjacent to that ulcer and decide whether or not there's T1 marrow infiltration. And in this case, we did not actually have an ulcer. This is the beginning of just some soft tissue swelling, and there's no osteomyelitis. This contrast enhancement is this reactive joint fluid and reactive joint effusion shown here. Looking at Charcot and osteomyelitis, what we're doing on the x-rays, we're going to be looking for any area where we perceive that there might be a soft tissue defect. And here, again, mastering our x-rays becomes imperative. So we want to see that this soft tissue lucency here is a large soft tissue ulcer. And when we look at the edges of the bone, we can see that the cortex is maintained and there's no focal definite erosion. We can see that there's some changing topography, but it doesn't look like there's an actual erosion here. So there would be an indication in this case to do that MRI to be able to assess whether or not we're seeing that with clarity, because remember that x-rays are not sensitive or specific enough to just make the diagnosis of osteomyelitis alone. So we'll move on to see that the MRI in this patient shows that soft tissue ulcer, and indeed some of the early changes seen here between what's left of the cuboid and base of fifth metatarsal in this patient who has recurrent osteomyelitis. In our patients with Charcot and osteomyelitis, this is an example that when we see that soft tissue ulcer, in this case adjacent to the cuboid, we can now appreciate the changes along that plantar aspect of cuboid where there's this T1 low signal change. We can see here the elevated T2 signal in the presence of an ulcer consistent with cuboid osteomyelitis. Are you ready to take your podiatric imaging skills to new heights? Check us out at radpodsquad.com. Explore our online learning community. And don't forget to like and subscribe to our YouTube channel for more enriching content.